This lecture will be part 1 on transplantation. Now, before we begin this lecture, here are a few terms that you will need to understand. The first one is autograft. Autograft is a transplant with an individual's own tissue. The example of this would be receiving blood that you had banked before surgery. Isograft is a transplant from an identical twin tissue. An allograft is a transplant between non-identical members of the same species, and a xenograft is a transplant from a member of a different species. With autograft and isograft, there's really not a problem with the immune response because all the cells of the donor and the recipient are identical. In the case of allografts, the immune response is dependent upon how closely the transplanted tissue matches the recipient. The greater number of markers, which we're going to talk about in a minute, are HLA markers, that match, the less the immune response and the greater chance of graft survival. With a xenograft transplant, the antigenic differences are so great that the incidence of rejection is very high. Now, the rejection process is an attack by the immune system. So this is going to be a review of some of the cells related to immune function. Monocytes are located in the general circulation and lymphoid tissue. They are mature cells that patrol the system for foreign antigens. Macrophages are monocytes that move into tissues which become large and capable of phagocytosis. And antigen-presenting cells, or APCs, are a special type of macrophage that present foreign antigens to T cells and B cells, which initiates a specific immune response. It actually starts the process of rejection. Neutrophils are also capable of phagocytosis and can release enzymes that digest cell walls of bacteria. Eosinophils have weak phagocytic activity, and the count usually rises during parasitic infections and allergic reactions. Basophils secrete locally acting messengers that prevent coagulation, produce vasodilation, and stimulate pain fibers. Mast cells are basophils that leave the blood and move into the interstitial fluid and are scattered throughout the body. And lymphocytes are the T cells and B cells, which we're going to talk about more in a minute. So we need to look at the process of phagocytosis, and in particular those with the antigen-presenting cell. That antigen-presenting cell comes in contact with a tissue cell, and it engulfs that tissue cell, and it forms a phagosome, which is a sac containing the tissue cell. It then combines with a lysosome, and lysosomes contain the material that destroys the foreign cell. And then they process that tissue cell. And just think about placing a liver into a person. What will happen? Now, this is just a picture of an antigen-presenting cell taking up a liver cell in the process of phagocytosis. Now, what triggers the phagocytosis by the APC? Well, it is distinguishing self from non-self. So antigens are any substance capable of triggering an immune response. And antigens announce their differences by shapes that protrude from the surface of the cell wall. They're also called epitopes. Class 1 MHC, or major histocompatibility complexes, are markers of self that appear on almost all body cells. Class 2 MHCs are markers of self that are found on B cells and macrophages. So this is what it looks like. This is the antigen-presenting cell. and it is roaming around, and it connects up with some tissue to see if it can recognize it. It determines if, yep, you belong here, or nope, you do not. And then this is the same process that goes on with B cells or macrophages. Now, what we're particularly interested in is the specific immune response with B cells and T cells. And they have a process of recognition, activation, and attack. Now, just a little bit about lymphocytes. We have two types of T cells. We have regulatory T cells, and they're also known as CD4, that orchestrate the immune system, including helper T cells that activate B cells, other T cells, natural killer cells, and macrophages, whereas suppressor T cells, or CD8s, turn off the system. And there's a specific type of T cells known as a cytotoxic T cell that directly attacks cells that are infected or malignant. These cells are responsible for the rejection of transplanted tissue. Now, T cells work by secreting lymphokines, and they promote cell activation, encourage cell growth, direct cellular traffic, destroy target cells, and incite macrophages. So we're going to look at this process. If you start at the top and think about this as two processes that are interrelated. You have the activation of helper T cells. And as you see in the corner, the antigen is processed and presented along with the class II MHC proteins to immature helper T cells by the APC. This involves the process of phagocytosis, which is going up in the top left corner. Then interleukins assist the helper T cell to be maturated. And what you end up with is a mature helper T cell. Now, in the second half of this is the activation of cytotoxic T cells. Remember this because they are involved in acute rejection, which we're going to talk about more towards the end of the second part of the lecture. They come in contact with a non-identical major histocompatibility complex antigen. The antigen is again processed and presented along with the class I major histocompatibility complex to immature cytotoxic T cells by the antigen presenting cell. That mature helper T cell that we made in the first part of this releases interleukin that assists in the maturation of the cytotoxic T cell. The mature cytotoxic T cell enters the circulation, finds the antigen-specific foreign body, and attaches to it. It then releases the contents of its secretory vessels into the extracellular space around the complex, and the contents consists of pore-forming proteins that insert into the target cell, resulting in death. So the upshot is, the first part, the antigen-presenting cell, processes the antigen, a little bit of interleukin is added, and you get a mature helper T cell. In that second process, that same antigen is processed, and it is presented to a cytotoxic T cell that recognizes it. And then that mature helper T cell, along with a little bit of interleukin, comes along and helps that cytotoxic T cell to mature. And then that mature cytotoxic T cell, in this case we'll think about the liver, goes down to that liver, attacks it, essentially pokes holes in it, and that tissue dies. Now, B cells produce antibody. Each B cell displays on its plasma membranes a copy of the antibody it is capable of producing. This surface antibody acts as a receptor for antigen. Any B cell produces antibody with unique antigen binding sites. This uniqueness was predetermined while undergoing maturation in the bone marrow. Now, there are several different classes of antibody. IgMs protect the extravascular compartment from microbes and toxins. IgM is the first line of defense for microbes in the blood. IgA protects mucosal surfaces. IgE protects intestinal parasites and is responsible for symptoms of allergic reactions. And IgD influences lymphocyte function. More specifically, the functions of antibodies are to disable foreign antigens, have a process called opsonization, which actually covers the foreign antigen in, we're going to say, a tasty fluid so that the cells of the immune system will go after it. They activate complement. They block viral entrance and mark foreign cells for attack. So we're going to look at that process of B cell activation. If you start at the top, an antigen is recognized, engulfed, and processed. Then class II proteins and the processed antigen are exposed on the surface of the B cell. Those helper cells from the last segment, the helper T cells, binds with the complex. Interleukins are released that activate the B cell. The B cell is transformed into a plasma cell. An antibody is formed. It leaves the lymph node and travels to the site, leaves the blood, and attacks. This is known as a humoral event because it was first discovered in body fluids or humors. So in this case, we have the same antigen that's processed, put out on the top of the cell, and along comes a mature helper T cell with a little bit of interleukins thrown in, and you get a plasma cell that produces antibodies that go down and assist in the destruction of whatever tissue cell is not supposed to be there. Now, there are a few other factors in immunology, and one are cytokines. IL-1, which is a cytokine, is produced in response to damage, infection, and antigen. Its functions include increasing natural killer cell activity, increasing the chemotaxis of white blood cells. It increases permeability, increases activity of macrophages, and helps in T cell proliferation and B cell proliferation. IL-2 functions as a T cell proliferation, the release of gamma interferon from T cells, the promotion of T cell growth, activation of monocytes and natural killer cells. Now, natural killer cells, they actually roam around in the body and the lymph and are capable of lysing cancer and virally infected cells. And complement is a family of proteins that circulate in the blood in an inactive state. Upon a complex cascade of events, a membrane attack protein, or a MAC, is formed, which embeds itself into the foreign tissue, disrupting the membrane and destroying it. Functions include, again, that opsonization, or making it tasty, the lysis of target cells, agglutination, neutralization, chemotaxis, activation of mast cells and basophils, and enhancement of inflammatory effects. So, just a quick review of the rejection process. Macrophages come in contact with the donor, in this instance will be a liver, antigens that are MHC1s that are then phagocytized. The APC macrophages process that foreign antigen and present fragments of it to T cells in the lymph node. IL-1 is produced, which promotes lymphocyte multiplication and activation. Other lymphokines are produced by activated T cells, for example, that IL-2, which promotes T cell growth and stimulates natural killer cell growth. It also stimulates B cells to produce an antigen-specific antibody. Complement is activated, and cellular death and then graft failure occur. Now, what is extremely important for you to understand is the immunosuppressive therapy that has been developed to stop a lot of those processes that we just talked about. What is most important that you remember is to make sure that the patients get these meds on time to prevent rejection. And I'm going to cover 3 of these meds in depth, which you should know. The first one is corticosteroids, which I'm sure that you have been beaten over the head about. They suppress inflammation and the immune response, and they're used to prevent organ rejection. However, there are a ton of adverse effects, including depression, euphoria, headache, personality changes. They also cause hypertension and GI bleeding. So you have to make sure that they get prophylaxis with Nexium and other proton pump inhibitors. They also cause nausea, vomiting, and anorexia. They can cause acne, decreased wound healing, ecchymosis, facial hair, and petechiae. They suppress the adrenals, cause fluid retention and decrease potassium, thromboembolism, muscle wasting osteoporosis, Cushingoid appearance, and increased glucose related to gluconeogenesis. So what do you need to do as a nurse? One is you need to assess adrenal insufficiency, hypotension, weight loss, weakness, nausea and vomiting, and confusion. You need to monitor their intake and output and weight. You need to check their glucose levels, potassium, white blood cells, and lipids, and check for bleeding, for example, occult blood. And give this in the AM with food to decrease GI symptoms. Now, the next most important drug is cyclosporin, and that interferes with that T cell activity in particular. And again, it is used to prevent organ rejection. Adverse effects of these are that they're nephrotoxic, they're hepatotoxic, it causes hypertension, it increases the risk of infection, they cause tremors, and particularly fine tremors, it decreases white blood cell counts, it causes diarrhea, nausea and vomiting, and in particular gum hyperplasia. Nursing implications: you need to monitor the CBC, liver function, and kidney function. Especially the first IV administration of it, you need to keep the crash cart at hand for possible anaphylaxis. You need to protect this IV infusion from light, and if it is olive oil based, you need to mix it with milk, especially chocolate or orange juice at room temperature, because it really is a nasty tasting drug. You need to notify the MD of any oliguria or bruising. For teaching, you need to teach your patient to take it with food, report the signs and symptoms of infection and bruising, use good hand washing, and avoid sick people. The third drug that you need to know about is azathioprine or Imuran, and it alters antibody production for those B cells. It prevents graft rejection. Adverse effects are hypotension, pulmonary edema, hepatotoxicity, nausea, vomiting, and diarrhea, stomatitis, alopecia, bone marrow suppression, and skin rash. So nursing implications include, again, monitoring their CBC, liver and kidney function, and monitor for infection. As far as teaching goes, your patient needs to know that they need to take it with food, to report signs and symptoms of infection and bruising, good hand washing, and avoid sick people. Now, these are other types of immunosuppressive therapy that you may come across. But once again, what is most important is these meds need to be given on time to these patients to prevent the process of the rejection of their new organ, be it a liver, a heart, or a kidney, or whatever, so we don't have that process started off. And this is the end of part 1 of immunosuppressive therapy.